we don't get major individual behavior change from biometrics over the population.
Yeah, I mean, let's assume we would know from biometrics, first of all, because I'm still not sure we would know.
Okay.
But yeah.
But what if biometrics provide enough detail about a specific population for the senior leaders to take notice and in fact work as a gateway to those proven interventions? Would you then say it's worth doing them if they give enough of a window and a picture, and it might even not even fall under that category of evaluation, but rather enough information for the senior leaders in an organization to say, okay, well then we're going to make an investment and tell us what the evidence-based things are we can do.
So, so you're saying at the front end we would want to do a check just so that we could say, how big a problem is this? That's a reasonable approach. I would argue if you're going to do that, though, that you would want to pick a sample of people and actually go measure that sample and measure them really well, because you can then generalize from a, you've got what, 150,000 covered, 150,000 workers.
Yes, please.
Yeah. And let's say you get 20% to do biometrics, right? So that's 30,000, right? I could go out and do a sample of 1,000 and learn much, much more to generalize to the whole population from 1,000 people where I really picked them and I got them all to do it than I could for 30,000 where there was just 30,000 people who kind of wanted to do it. I mean, the truth is I don't know what I've got when I have 30,000 people who kind of want to do it. If I've got 1,000 people who I know, I picked them at random throughout and I got them all to do it, or I got maybe better than 70% of them to do it, then I really know where I'm at. And I think it's a better way to think about spending your money if that's the reason you're doing it, is to sort of get the picture at the beginning, is to pick samples. And this is not rocket science. I mean, this is kind of one-on-one. I mean, this is kind of like 101 in my world, but it is. It actually is a more cost-efficient way to do it, if that's what you want to do. Yeah.
You have suggested that the studies are saying that HRAs are not effective themselves in getting people to change. And we've talked about that, and we've said that without follow-ups, interventions, all those different things, that they're not going to be effective. But what, at least I think, one of the main indicators we're seeing that we keep talking about is that people were not aware. Unlike with HRAs, I mean, a lot of people were not aware that they have a risk factor. Perhaps some people are aware that they are overweight, but even in the responses we received, they were not aware that their waist circumference was above recommended level. And certainly a large percentage did not know that they had elevated blood pressure. Frankly, the standards have even dropped in the last 10 years as to what's deemed to be healthy.
Right.
So to me, that seems like that's a really significant statistic right there, and that a lot of people being made aware of risk factors that they never knew of has to be beneficial. I mean, but maybe not beneficial enough. I don't know.
It costs a lot to do it. The question really is it beneficial? I mean, do they do things differently because of that? And the evidence that we've got seems to be no, that alone isn't enough. And so, and again, why did the U.S. Preventive Services Task Force not recommend the diabetes screening? Because it's still not clear in the general population, of people of a healthy weight, that you actually can affect their long-term outcomes by finding people, that rare diabetic that who is of a normal weight, and get them into treatment. It's not clear that it makes any difference in their lives. And again, this is the group that we pay as a nation to go and give us their best thought on what the science tells us, and they're telling us, they're not anti. I mean, they recommend lots of screening. These people love the screening, but they looked at this and they still say, we just don't see. It's the same reason we dropped lung cancer screening in this country. I don't know if you know, we used to screen for lung cancer. We used to do chest X-rays. But when I was getting trained, everybody we took a look at it and we realized that all we were doing was making people sicker for longer. We weren't lengthening their lives. We were just telling them they had lung cancer sooner, and it wasn't actually making a difference in their lives. And it's part of the same reason that we don't recommend prostate cancer screening in general, because 97% of people with prostate cancer are going to live for 10 years anyway. And so it isn't clear that we're affecting their lives. So the question is, do we know what to do about it? It's the same. So so it isn't necessarily better that people know, actually. I mean, I think you just have to, that's a basic principle of screening, is if it isn't clear what you're going to do about it, and it isn't clear that it makes a difference, then it isn't actually, then you spent a lot of money and actually created a lot of angst, because those people are now labeled, right? You have told them, we've lowered these levels, and not everybody thinks it's absolutely great that we've lowered and lowered and lowered these levels. And especially, again, and so what have we done? We've made a lot of people sick who used to think they were well. And that's the danger. I'm a prevention guy. I've devoted my life to it, but it's the first slide I give in my lecture to my medical students, is that one of the dangers of screening is that you take people who are sick, you take people who are well, think they're well, and you make them think they're sick. And you better be sure that you're actually helping them when you do that, because have you ever, I don't know if you've ever had a positive test. I mean, as a guy, you get screened less, but women get screened a lot. And you talk to women, lots of them have been through those false positive mammograms and false positive pap smears, and they know what the cost of that is. And as a husband, I've been through that terror quite a few times. And so again, these things, if they're clear benefits, that's great. But if there aren't, you're not actually doing anybody any favors. And the truth is, whether they say they know it or not, a lot of those people actually have heard before, they just haven't internalized it. And the question is, are they going to internalize it and do anything about it this time?
Interesting.
We'll take Kyle in a minute.
Thank you, Catherine. As far as the weight and BMI and things, should health and productivity coordinators choose to evaluate BMI or choose to evaluate weight? In your slides, of course, very little is expected to gain, and should it even be a part of what we're really looking to evaluate a successful program on? Or should it be more about those behaviors, the physical activity, all these other things, because they equate better to longer term health?
Well, my answer to that, I guess, is should we be trying to measure the weight of our population, of our working population, as an outcome if there were a way to do that inexpensively for a sample? Sure, of course. It's a good thing to measure. It's something we really care about. It turns out that you can do just about as well asking people as you can by physically measuring them, and it's a lot cheaper. You'll get lower levels, okay, a little bit lower, but it's reproducible, and it gives you a fairly good idea. But again, you get back to that generalizability issue in picking a sample, so rather than picking the worried well, so that you actually get a fair number of people. At the individual level, for the general population, I don't think the evidence is very good that it makes a big difference. It is recommended, by the way, by the U.S. Preventive Services Task Force. When they've looked at the cost effectiveness of it, it's way, way, way down the list, because the evidence that it actually makes a difference, at least for the average person, isn't very good in terms of getting them to do something. If people are overweight or obese, that's a different story. But again, you got to move them on to counseling.